Just going to talk to you about this particular paper, which I looked at some months back, actually. I thought I was going to present in October, but then things got sort of filled about. But I thought it would still be interesting anyway. Just a study comparing Tirzepatide versus Semaglutide once weekly in patients with type 2 diabetes. So just a bit of background. Everybody now knows the GLP-1 analogs have been around for a long time. There are lots of them now. They're seen as something of a revelation in the management of type 2 diabetes therapy. Multiple different benefits, both clinical and physiological. So these are the benefits of GLP-1 analogs, which have been around for a long time. And obviously people know the common formulations. They're obviously mostly subcutaneous, not exclusively. Exenatide has an oral form, and obviously there's a lot of excitement about oral semaglutide as well now. But in general, these are why these are such valued agents now in the management of type 2 diabetes. But there's another polypeptide which is of interest in type 2 diabetes, and that's GIP, or glucose-dependent insulinotropic polypeptide. Now, this is an interesting polypeptide. It's both insulinotropic and gluconotropic, so it increases levels of both, interestingly. Now, the key thing about the receptors of this particular polypeptide is that they're present in the adipose tissues. And the benefit of this is that it will enhance the lipid buffering capacity of the white adipose tissue, and also the sensitivity of adipose tissue to insulin. And that will reduce ectopic fat deposition, ultimately is thought to reduce insulin resistance in the longer run. So the theory behind Tirzepatide, which is a combined GIP analog and GLP-1 analog, is that if you combine both GLP-1 agonism and GIP agonism, then it may have a greater effect than GLP-1 agonism by itself. And that brings us on to Tirzepatide, which is, as I mentioned, a dual glucose-dependent insulinotropic polypeptide and GLP-1 receptor agonist. And sharing the benefits of agents like Trulicity, it has a half-life of 5 days, so it allows weekly administration and therefore can reduce the burden of non-compliance in some of these patients as well. So it had already been trialed. There'd already been phase 2b trials that have gone on with Tirzepatide, which has shown a dose-dependent reduction in HbA1c and weight with Tirzepatide. But this was the first major clinical trial comparing it against Semaglutide, which is seen as the most effective GLP-1 analog on the market at the moment. Just a bit of background on Semaglutide. I had briefly introduced it, but as I'm sure you all know, it's selective GLP-1 receptor analog. It's a once weekly injectable, and it's approved now for use in type 2 diabetes in dose up to 1 milligram. So typically start at 0.25 milligrams, up titrate every few weeks if well tolerated. I did mention there's a lot of excitement now about Rybelsus, the oral agent, but that wasn't specifically tested in this trial. The previous data on semaglutide said that it can achieve reductions in weight of up to 6.5 kilograms, as well as reductions in HbA1c of 1.8%. And old money, or rather new money, that's the HbA1c reduction of about 15 or so millimoles per mole. So the aim of the trial, so this was called the SURPASS-2 trial. So it was comparing Tirzepatide against semaglutide as add-on therapy to metformin alone in participants with type 2 diabetes mellitus. So these were people at the first stage of intensification. And the study was comparing Tirzepatide at 3 different doses, 5, 10, and 15 milligrams, with semaglutide 1 milligram. So the maximal dose of semaglutide against 3 different doses of Tirzepatide in patients who are inadequately controlled on metformin alone. By way of background, as far as methods go, it was a 40-week trial. It was open label, so everybody knew what they were taking, which had to be the case anyway because of different doses. It was randomized active control, and it was a phase 3 trial. And it was many different countries were involved, so the States, Argentina, Australia, and there were centres here in the UK as well. So the criteria were patients had to be adults, they had to be on metformin alone at quite hefty doses, 1.5 grams per day, have a HbA1c of between 53 and 86, with an elevated BMI of over 25. And they need to have had a stable weight of the prior 3 months. So it must have essentially failed lifestyle measures as far as weight loss goes prior to enrollment into the trial. The exclusion criteria are obviously type 1 diabetics. I mean, there are obviously cases where GLP-1 analogs are being used in type 1 diabetics if there's superimposed insulin resistance or weight loss would still be felt to benefit them. But they weren't included in this trial. If they had CKD3B, essentially, EGFR 145, if there was a history of pancreatitis, and of course there is concern with GLP-1s analogs and the small risk of pancreatitis with that. And then if they had non-proliferative diabetic retinopathy requiring urgent treatment, or proliferative diabetic retinopathy, or any sort of maculopathy in either eye, those patients weren't included. So the way they structure the trial, essentially they divide all the patients up into 4 groups. Equal numbers were put into the 5 milligrams, the 10 milligrams, the 15 milligrams of Tirzepatide against the 1 milligram of Semaglutide. In terms of titration upwards, the Tirzepatide was started at 2.5 milligrams once a week, and then increased by 2.5 milligrams every 4 weeks until the dose was assigned, so whether that be 5 or 10 or 15. And the Semaglutide was started at 0.25, which is fairly standard clinical practice, with a dose doubling for every 4 weeks until the maximum dose was reached if well tolerated.
How many patients in each group were there?
Yeah, so I think...
Oh, here it is, yeah.
Yeah, so it's over here, yeah. So it was, these are the baseline data for the, or the baseline characteristics of the patients. So it should say here somewhere how many patients there were.
Yeah, it's at the top. It's at the top.
Yeah, exactly. So about 500 or so. Yeah, just under 500. Yeah. So in terms of age, you can see sort of middle-aged, 56, mid to late 50s, essentially. Roughly equal gender balance between the two. This is the things about ethnicity, which one of the weaknesses of the trial is probably that it didn't have a high proportion of Black patients in either trial. There's only a 5% or so. We'll talk about that later. And then this is their baseline HbA1c. So you can see roughly the HbA1c was around about 8.3% in old money, which in new money is about 70-ish. Or so 68 or 67.5, yeah. And then this is their serum glucose. Obviously, this is in about 10 for most patients, 9 to 10. And they'd mostly had diabetes for about just under a decade, coming close to a decade by this stage of their treatment. And their BMI was usually well over the target range, so well into the 30s. And this is their EGFR. So most of them had EGFRs above 60, so essentially normal renal function to all intents and purposes. And most of them also didn't have microalbuminuria, so they were essentially complication-free. A minority did have some microalbuminuria, and a few were profound albuminuria. So as mentioned, all of them were on metformin, and their blood pressure is reasonably well controlled for the main part. So the endpoints of the study, the primary endpoint was to see what the change in HbA1c would be from baseline to week 40. And there were various secondary endpoints that they were looking at too. One was the change in body weight from baseline to week 40. One was the attainment of HbA1c of under 53 and a HbA1c of under 39 without accompanying hypoglycemia. And then another endpoint was under 58, but in the context of weight loss of 5 kilograms, of 5, 10 or 10, 15%. They were also looking at the mean change in fasting serum glucose, BMI, lipid levels, and HOMA-IR readings as well as fasting glucagon levels. So obviously isn't a test that we routinely do in clinical practice. So these are the results. So essentially, this is the primary endpoint, which is the change in hemoglobin level or HbA1c level from baseline. And so this is semaglutide, and this is tirzepatide at 5, 10, and 15 milligrams. And actually, in all of these groups, the tirzepatide was significantly better than semaglutide at reducing the HbA1c from baseline. So there's statistically significant probability in all of those groups. And this is another graphic of the same statistic essentially. So the semaglutide brought the HbA1c down to 6.42%, whilst the highest dose of tirzepatide brought it down to 5.82%. And then this is the percentage of people of patients who met the glycated HbA1c target. And again, it was significantly higher in the tirzepatide groups than the semaglutide group. So both at under 7%, under 6.5%, and under 5.7%, which is 39 millimoles per mole. So that's 39, that's 48, and that's 53 in new money. So significant improvements in people achieving essentially non-diabetic HbA1cs. This is the fasting serum glucose, which again shows a similar pattern with the higher the dose of tirzepatide, the greater the reduction in fasting serum glucose, essentially.
A good dose of semaglutide.
Yes, so it's 1 milligram of semaglutide, yes. These are the secondary endpoints. So it was, if you remember, I talked about change in body weight. So again, the tirzepatide here was convincingly better. So, and again, the higher the dose of tirzepatide, there was statistically significant improvement in body weight. So semaglutide 1 milligram typically led to an average of 5.7 kilograms weight loss, whilst the highest dose of tirzepatide managed to achieve almost double that, essentially.
Hi, Vicky, can I ask a quick question? Do we have any idea about equivalence of semaglutide 1 milligram and tirzepatide with any of those three doses in terms of its GLP-1 dose? Because actually the semaglutide 2 milligram data is much better than tirzepatide 15. So what are we comparing here?
Yes, this is 1 milligram only, so we haven't looked at 2 milligrams. So, but yeah, it's a good question. So I did try and see. I don't think anyone's specifically assessed how much. I mean, I don't think we know exactly how much GLP-1 versus GIP-1 antagonism there is, or what the predominant mechanism is for tirzepatide.
Well, what we need is a dose response, as they've done for tirzepatide, don't we? We need a dose response to see if there's a dose. I mean, in fact, even tirzepatide hasn't plateaued. It might keep going down, and you could give higher doses.
Yeah, there is very good separate study dose response for semaglutide, and actually what's really interesting is that the HbA1c reduction in this study with 1 milligram semaglutide is identical to what the Novo trials have shown just on semaglutide on its own. And so if we had an equivalent bar, the semaglutide at 2 milligrams or 2.4 milligrams would be much better than tirzepatide at 15.
That's something I was going to touch on actually. That one of the.
Sorry. I'll leave.
No, that's fine. No. Thank you for highlighting it. No, it's a very important point. Actually, we don't know how.
Yeah, could I make a quick comment? Sorry,
sure.
Mustafa. So, so this is more selective for GIP, obviously.
Yeah.
So. It doesn't surprise me what Vicky is saying. At the end of the day, the 2.4 milligram semaglutide data gives a 15% weight loss. So that would be, as she's saying, better than the 13% we're getting with tirzepatide. So, I think that question is really important, because I haven't seen anything written about the dose response curve for tirzepatide, but that I think would be something we should look for.
Yes, absolutely, yeah.
Here's Alex as well.
Yeah, sure.
Sorry, we are interrupting in the middle, but just to say that the semaglutide 2 milligrams compared to 1 milligram is not fantastically different, all right? In terms of HbA1c or weight loss, it's a little bit better, but not fantastically so. With regards to so I don't think that the 2 milligrams or 2.4 milligrams would be much better than the 15 of tirzepatide. You should expect with the 2 milligrams about a 10% weight loss. So tirzepatide 15 is is slightly better.
No, actually, the 2.4 gave a 15% reduction.
No, but this is in people with obesity and without diabetes.
Exactly, with obesity.
Yeah, but it's not the same. So people
It's not the same. I agree. Yeah.
So people with diabetes get less weight.
I mean, because the 2.4 is really for the obese population. But you know, I do think it's important to see the GLP-1 potency with both of these, so that, because I don't think we're comparing the same with same, if that makes sense.
I don't think the aim was to compare same with same. I think the aim was.
I know, but in the sense of potency of GLP-1 agonism.
Yeah, that's a different study. Yeah.
Carry on, Mustafa.
Yeah, sure. So this was, again, another graphic to demonstrate the difference in weight loss with semaglutide compared to the escalating dose of tirzepatide. And again, the patients who met the weight loss target, so about half achieved 5% or greater weight loss with semaglutide, but that went up to 80%. So the overwhelming majority really went with the highest dose of tirzepatide, and again, a significant majority with the lower dose of 10 milligrams. There was also some data on the change in lipid levels. So there was a greater reduction in triglyceride levels with the tirzepatide as compared to the semaglutide, and again, that was significant, and that also applied to the rise in HDL cholesterol with the tirzepatide, and the reduction in LDL was actually less convincing and not so different between the different groups, but the rise in HDL was significant with the tirzepatide as compared to the semaglutide, as was the reduction in VLDL. This is some data on adverse events. To cut a long story short, essentially the authors didn't feel there was any significant difference in adverse events. Obviously, there are issues with tolerability of GLP-1 analogs, but this data would suggest that the rates of nausea, vomiting, diarrhea are generally fairly similar between the tirzepatide and the semaglutide. And there weren't any, in terms of hypoglycemia and severe hypoglycemia, again, the rates were very low in all groups. And again, no significant difference in pancreatitis rates as well, or worsening of diabetes.
Sorry, it's me again, and maybe Alex can comment on this, but there is actually, I mean, certainly with high dose tirzepatide, double the number of people who discontinue the drug. And I seem to recall that the phase 2 studies with tirzepatide were associated with really, really high levels of adverse events and discontinuation when they started straight off at the high doses, with a suspicion that this stuff was much more nauseating than GLP-1 alone. So be interested to hear what people think about this discontinuation data.
What does when you say very high, what do you mean, Vicky?
I don't want to quote because I can't remember, but I seem to recall that with the phase 2 studies of tirzepatide, they went straight in without dose escalation, and they had really, really big dropouts. Maybe Alex can remember that data. I'll quickly look it up now, but there's been a lingering question as to whether GLP-1 GIP analogs are less well tolerated.
So here it's about 300, quite a lot of people, isn't it? 60% of patients had an adverse event, and then they're listed here. It's very small percentages with diet, nausea, and so on.
Yeah, at the high dose tirzepatide, twice the number of people discontinued the drug compared to semaglutide, but it's slightly more at the lowest dose. Okay. And if we were assuming tirzepatide 10 is comparable to Sema 1, it looks as though it is less well tolerated.
Okay. So just what proportion of people discontinued the drug, Mustafa, on this table? There's a lot of data.
So here, it's over here. So 6%.
Yes.
6% for the 5 milligrams, 8.5% for the 10, 8.5 for the 15, and 4.1 for the semaglutide. So actually, in absolute terms, not a big difference, but that may be significant. Actually, they haven't said.
They haven't, but I mean, you could, it is how you interpret it. You could call it doubling of 4 to 8, or you could say, Okay, but that's the raw data. Thank you. Okay, carry on. Sorry, I'll stop interrupting.
Yeah, not at all. No. Please do, yeah. So these were the conclusions from the authors, that tirzepatide at all doses was both non-inferior and superior to semaglutide 1 milligram at both reducing HbA1c and body weight. That tirzepatide 15 milligrams produced double the weight loss of 1 milligram, and then a significant proportion of those achieved HbA1c of under 39 without associated hypoglycemia. There were additional benefits on lipid profile, blood pressure. The HOMA-IR also improved. Obviously, that's mostly a research tool, but and then liver enzymes as well. And then the subsequent conclusion was that the dual agonism of both GIP-1 and GLP-1 was therefore potentially of greater benefit than GLP-1 alone. And the GI side effect profile was broadly similar, despite a slightly higher dropout rate with tirzepatide compared to semaglutide. I mean, there were a few limitations of the trial that I noted. One was that obviously the treatments weren't blinded. They couldn't really do anything about that though, because by definition, different doses had to be taken. Ultimately, we only looked at 40 weeks, and it's difficult to postulate what may happen beyond then. So it'd be interesting to see whether those effects, that greater benefit from tirzepatide, whether that would really last 2 years or 3 years or 5 years down the line. We don't know that yet. As I alluded to earlier, there's a lower number of patients of African origin, which would be an issue for our potentially for our population here in London. As we've already spoken about, the higher dose semaglutide hasn't been considered in all of this. So we haven't done a direct comparison of the high dose semaglutide with the highest dose of tirzepatide. I mean, there was the strengths of the trial was that the 1 milligram semaglutide data was fairly consistent with what we found before in the SUSTAIN and the STEP 24 trials. There were significant numbers of patients overall, so 500 in each group or so. And this is thought to be a good foundation to go on to compare tirzepatide with semaglutide and glargine as well. And then there is also the references here as well for people who want to read into it further. You do get free access with the New England Journal to 2 articles, so this can be one of them.
Thank you. I think, just say that again, Mustafa. We missed the last bit. Your sound went off.
Oh yeah, I was just saying that you can get free access to 2 articles with the New England Journal, 3 articles. So this can be one of them.
I see. Okay. I think, yeah, okay.
So yeah, any other thoughts from the audience then? And any idea when this may
When it might appear.
clinical practice in the UK from our obesity experts?
Alex thinks it'll be here by the end of the year.
Oh wow, so very soon. Okay.
So Alex, are you going to use it? Are you convinced to go from Novo to Lilly?
You need to come here, Alex. I can't hear from there.
So that's a very good question. And there's an off the record and an on the record answer. The on the record is that, yes, I will for diabetes. They are doing a trial for obesity, and I think the obesity trial will be very impressive. But that will take, I think it will report in 2024 at the earliest. So it will be
That's a really long study then.
the obesity one. They've started. Yeah. So it will take time for this to become obesity. What will happen is that, therefore, that this might start getting used out of license for obesity. But yeah, I will go. I will go to whatever is seems to be better, unless, as you say, the side effects are really bad.
So you're convinced that it's better at HbA1c reduction?
How much was that?
I'm not convinced that it's that much. I think it's 6 or 1/2 a dozen of the other actually at the moment. But for me, the game changer would be if there was an added metabolic impact, for example, on liver disease, etc. So do you know of any evidence that the addition of a GIP agonist is going to have above and beyond effects on, probably not lipids looking at that data, but on fatty liver, for example?
I don't know about GIP and fatty liver,
We
to
don't
be
know
honest with you.
if it's one drug, do we? We don't know if it's one part or the other.
Yeah, that's the right. Well, yeah, I suppose you're right. Because it's a it's a bimolecular, it's a single entity. It's difficult to know which one is doing the job, whether it's a GLP-1 or the GIP. But I don't know what you're asking about, whether GIP on its own, what effects it has on fatty liver. So I'll be honest with that. But can you remind us what the HbA1c reductions were? Because I think I couldn't see it.
Yeah, sure. Let's have a look. It's yeah, so the difference in HbA1c reduction between the semaglutide and the highest dose of tirzepatide is about 0.6%. That's the difference in.
Yeah, so
You'll reduce it. Yeah, so if the mean starting point was 8.3%, the semaglutide brought it down by about 1.9%. Was the
yeah, so
tirzepatide brought it down by 2.4 or so.
Yeah, so 2.3% HbA1c reduction. Just to say that overall, this is really impressive. But I agree with the HbA1c reduction. You're right. I think that there will not be a major difference between the two.
It's Shivani here. Just following on from that, because I missed a bit in between. The changes in the metabolic parameters, including I think there were biomarkers of insulin sensitivity, etc. Do we know that those are independent of weight loss and HbA1c reduction? Because that would be.
I don't think we do actually. No, I don't think we do.
Well, you mean on which metabolic markers?
I did miss a bit, but Mustafa, didn't you say that there were improvements in the biomarkers of insulin sensitivity?
Yes, so it was reported there was improvement in HOMA IR, but they haven't actually given us the exact figures. They just said there's an improvement. They've not attempted to quantify it.
There's an article by Ferranini about tirzepatide and insulin sensitivity, and he goes through possible mechanisms of the fact that this does increase whole body insulin sensitivity by various, I can't remember the details, but there is this idea that this does increase sensitivity independently of weight loss.
That would be interesting. That would be really exciting. Why would it do that? I don't know.
Actually got a lot of, there's a lot of theories about the actual mechanism of action, about the dual agonism. I don't know if anyone has any thoughts of that, because GIP normally increases glucagon secretion. So I'm just, does anyone know the specific mechanism?
I think it's centered around GIP receptor
central
at the level of the adipocyte. But I mean, they used to say this about GLP-1 at the beginning until basically it's been debunked. I've never ever seen any evidence in rodent or man to suggest that the insulin sensitizing effects of these are anything above and beyond the weight loss.
And then the only other question I'd have is, obviously we're seeing, possibly superior weight loss, equivalent A1C control. But until the CV data comes out, you could still argue that SEMA would be preferred because of its CV and renal data. I don't know, because there's no data yet, is there? The CVOT is still going on.
I mean, if